Good evening, everybody. My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation Educational Series webinar. This evening, we're going to be talking about considering the needs of patients with refractory moderate to severe atopic dermatitis. Our moderator this evening is Dr. Sean Quatra, who is professor and chair of dermatology at the University of Maryland Department of Dermatology in Baltimore, Maryland. Our speaker this evening is Dr. Lisa Swanson, who's at the Ada West Dermatology in St. Luke's Children's Hospital in Meridian, Idaho. We'd like to thank our supporter, Pfizer, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues, please submit your questions using the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in the browser and will be emailed to you 1 to 2 days later. We'd greatly appreciate it if you could fill in the evaluation and send it back to us. Within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. Again, if you want to submit questions, use the question chat pane on the right-hand side of your screen. And we wrote a little note there so you could see where you need to write your questions. And if you have any questions that you think about after the webinar, you can always send them to info@idefeducationalseries.com. So without further ado, I will pass the floor virtually to Dr. Quatra.
Thank you so much, Roxanne, and thank you everyone for joining us here today. We're very excited about the session that we're going to have today. And again, thank you all for joining us. We can move the slide and we can discuss a little bit more about the International Dermatology Education Foundation. The president is my friend Leon Kircik. The IDEF is a nonprofit organization with the mission to raise awareness and improve dermatologic care all over the world through education, with a special emphasis on underserved areas. When you can see all of the different types of educational offerings. So there tends to be a weekly webcast, and you can see that there's quite a variety of different topics that are being covered, especially with many of new therapeutics in development. This has been very helpful to have coverage of a lot of these different topics. So it's really filled a big void. So today, it is my honor to introduce Dr. Lisa Swanson, who is also a pediatric dermatologist, an expert in atopic dermatitis. Some of you may not know this, but she's a Swiftie. She's a huge fan of The Bachelor, and she's also a dog mom. Those are just a few of Lisa's most important credentials. So I will give it off to Dr. Lisa Swanson.
Thank you so much, Dr. Quatra. Thank you so much for that wonderful introduction. Yeah, Sean asked, you know, how do you want to introduce yourself? Who's Lisa in a nutshell? And I immediately said, Bachelor Nation, dog mom, Swiftie. That sums me up completely. And I'm thrilled to be here tonight. So happy to be talking to you guys about considering the needs of patients with refractory moderate to severe atopic dermatitis. And so we'll go ahead and start right on in. So we see the title of our presentation here. We're going to be thinking about the needs of our patients with refractory moderate to severe AD tonight. We have the official indication for Sabinco, indicated for the treatment of adults and kids aged 12 and up with refractory moderate to severe atopic dermatitis whose disease is not adequately controlled with other systemic drug products, including biologics, or when use of those therapies is inadvisable. And this indication is really important because we need to pay attention to this when we're making our documentation in our clinical notes and we're anticipating prescribing a medicine like Sabinco. We need to make sure we have all our T's crossed and all our I's dotted. And if we're going to be prescribing Sabinco, we want to make sure that the patient is at least 12 years of age and older, that we document moderate to severe atopic dermatitis, that we document very clearly the things that they have failed. because if we're good with our documentation, it definitely makes the lives of our biologic and medication coordinators so much easier, and that's important because they provide an incredibly valuable service. So I want to make their lives easier. And so we'll go on, dive into the next slide, which is our disclosure slide. So I'm here, of course, on behalf of Pfizer. I'm presenting this information. I'm presenting this slide deck that's been created in accordance with FDA prescribing guidelines. And one of the ways you're going to know that I did not create this slide deck is that you will not see any pictures of my doggies during this presentation. And if I had created the slide deck, there would definitely be pictures of my doggies. And if afterwards you want to see pictures of my doggies, I'd be more than happy to try to show them to you. I could put them up there on the screen and give you a glimpse of little Maggie and Mose because they're real cute. This is an overview of our presentation tonight. We're going to talk about Sabinco, a small molecule JAK inhibitor that works inside the cell. We're going to talk about efficacy outcomes from the JADE clinical trial program. We're going to talk about safety, of course, very, very important, that's been evaluated in around 3,800 patients across multiple clinical trials. And then we're going to talk about the practical stuff, starting and monitoring your patients on Sabinco. What do you need to do before you start? What do you need to do in an ongoing fashion? And how do you talk to your patients about choosing an oral JAK inhibitor? I'm going to cover all that tonight, you guys, so get excited. So right here we have the indication again. We've reviewed that 12 and up, moderate to severe AD. We have our limitations of use. It's not recommended for use in combination with other JAK inhibitors, biologic immunomodulators, or other immunosuppressants, so that's important to keep in mind. We have, of course, a brief snippet of the boxed warning that's on the JAK inhibitors here in the United States. We're very familiar with this, and we're going to talk a lot about it later on in the presentation, but it's so important, we want it up front and center as well. The medicine Sabinco is contraindicated in patients taking antiplatelet therapies with the exception of low-dose aspirin, the 81 milligram baby aspirin, during the first 3 months of treatment. Reason for that: we did see some patients develop a little bit of a thrombocytopenia at the beginning of treatment during the first 3 months. So if you develop thrombocytopenia, you want to make sure the platelets you have are working at their utmost capacity. So you wouldn't want to be on an antiplatelet therapy in case that happened to you. And so that is why that warning is in there, which I think provides good context. Our American Academy of Dermatology guidelines for the treatment of atopic dermatitis have just been revamped. This is exciting, you guys. I think the last time these guidelines were looked at and evaluated, I think the Golden Bachelor Gary was still in high school the last time that these were looked at. For your knowledge, the Golden Bachelor Gary is 71 years young. So it was a long time ago that these guidelines were originally looked at, and it's been a long time since it's been updated. But we have these new updates because we have so many new therapies for the treatment of atopic dermatitis. So it's nice to see what these guidelines have to say. And these guidelines overall recommend abrocitinib, otherwise known as Sabinco, for adults with moderate to severe AD with a strong strength of recommendation. So that's really powerful. A, it's nice that they redid this. It's nice to see them revamped because, again, there are a lot of new kids on the block when it comes to treating atopic dermatitis. And B, it's nice to see that our oral JAK inhibitors were given a strong strength of recommendation for the use for patients with atopic dermatitis. Now, of course, it says adults here because these are the adult guidelines. They haven't yet released the pediatric ones. And so that's why it calls out adults here on the slide. I would sure hope, I'm a dermatologist and pediatric dermatologist, I would sure hope that new PEDS guidelines are on the way as well. So do you have patients who are experiencing uncontrolled or worsening eczema despite current or past treatment with systemics? Do you have patients who are still experiencing bothersome itch? Do you have patients who are concerned about the presence of lesions on their body, or patients who are just generally looking for a different treatment option? I bet that you do. I bet that you have some patients that meet at least one of these boxes. And so we're going to talk about an additional option that you can recommend and discuss with your patients. When I talk to patients now about atopic dermatitis, especially those with moderate to severe disease, I tell them this is a great time to have bad eczema because we have so many more tools in our toolbox than ever before. There's so many different ways that we can help these patients feel better and look better and do better and live better. And that's really empowering as a dermatologist. It makes my job so much more fun to be able to have things to talk about with my patients that can help them. So now we're going to talk about powerful skin clearance and rapid itch relief. Are you guys ready? Get excited. This is the good stuff. These were the trials of the JADE clinical trial program. So it was studied as monotherapy as well as in combination with topical corticosteroids. So first we had JADE Mono 1 and Mono 2. These were the monotherapy trials, as the name implies, 12-week studies. Sabinco 100 versus Sabinco 200 versus placebo, with typical co-primary endpoints of EASI-75 and IGA clear almost clear at week 12. Then we had JADE Compare, which involved the use of topical corticosteroids as well. And so these were patients who were 18 and up, and we compared Sabinco 100 versus Sabinco 200 versus Dupy as an active control versus placebo, an oral and injectable placebo, which is known as a double dummy placebo group. I feel like there's a joke there. I'm still working on it, haven't fine-tuned it completely, but double dummy, I mean, come on, there's got to be a joke hidden in there somewhere. Typical co-primary endpoints, EASI-75 and IGA clear almost clear at week 12. They also looked at week 16. Since the pivotal trials of dupilumab extended to week 16, they went out to week 16 in JADE Compare. And then JADE Teen, specifically looking at the teenagers, patients aged 12 to 17, Sabinco 100 versus 200 versus placebo, same co-primary endpoints. Patients that participated in any of these trials were allowed to roll in to the ongoing safety extension study. And so they could roll in to continue to receive Sabinco, or if they were on placebo, be randomized to receive Sabinco in one of its 2 doses. A quick reminder here, these studies were done comparing Sabinco 100 with 200. The FDA label approval is to start with 100 milligrams daily, and then you can increase to 200 milligrams a day if inadequate response is seen. So that's an important thing to note. It's nice in these trials to see both doses, but in the real life indication, we are to start with 100 milligrams and then advance to 200 milligrams if we need to, if we don't get the kind of response we're after. So now let's talk about JADE Mono 1 and Mono 2. In addition to the co-primary endpoints of EASI-75 and IGA clear almost clear, they also looked at itch improvement, itch greater than or equal to 4-point improvement at week 2, you guys, week 2. It's that fast. These JAK inhibitors really excel at working quite quickly to calm down the inflammation of atopic dermatitis. Now let's look at some data from JADE Mono studies. This is JADE Mono 2 in particular. This is looking at EASI-75 on the left, IGA clear or almost clear on the right. We see 2/3 of the patients on Sabinco 200 are achieving EASI-75. 44% of the Sabinco 100 patients are achieving that. And look at how quickly these Sabinco doses separate themselves from placebo. You see by week 2 a separation there. Again, these medicines work very quickly. In addition, looking at the right, IGA clear or almost clear, we see 38% of Sabinco 200 patients achieving IGA clear or almost clear, and 28% of Sabinco 100 patients. And again, you see that early separation at week 2, which really becomes much more profound at week 4. And again, this is over just 12 weeks, just 12 weeks of time. In the time it takes to watch a season of The Bachelor or The Bachelorette or Bachelor in Paradise. 12 weeks, you guys, the journey to find love. A significant percentage of these patients are achieving clear, almost clear skin, and a significant percent are achieving EASI-75. That's magic if you ask me. While you're enjoying The Bachelor, you can get your skin clear. This is looking at itch improvement at week 2. Week 2, a greater than or equal to 4-point improvement in itch. We see 11% of the patients in the 100 milligram dose are achieving that, 24% in the 200 milligrams. And again, just 2 weeks, you guys. From the time it takes to go from the fantasy suites to the after the final rose, that's 2 weeks, 24% of the patients in the Sabinco 200 milligram group are achieving an itch improvement greater than or equal to 4 points. That's really impressive and really great. And we love to see that fast improvement. Now, let's look at the absolute change in itch over time from baseline, because itch, real important, you guys, real important. And patients will tell us that. It's the itch that matters the most. They want to feel less itchy, and that's the number one thing. They'll wait for their skin lesions to look better. They just want to feel less itchy. And so this is looking at the NRS, the itch NRS numbers going down over time as the patients are involved in the study. We can see a clear separation between Cibinco and placebo on day 2. That fast, a clear separation. And it gets better. That itch number just keeps decreasing over time out to day 15 and then beyond week 4, week 8, week 12. The itch continues to drop over time. And our patients want to see that with a medicine that they're considering to control their atopic dermatitis. Itch is like, we always knew itch was important, but I think it's on a whole new level right now. Itch is really having a moment. It's on its own Eras tour. It's selling out stadiums everywhere because we're really starting to pay attention to the impact itch has, the burden that it is on our patients. Now let's talk about JADE Compare. You'll remember that this is patients 18 and up. They were allowed to use topical steroids. It was Cibinco 100 versus 200 versus Dupy as the active control, not a comparator, an active control. And then the oral and injectable placebo with typical co-primary endpoints and key secondary endpoints of itch greater than or equal to 4-point improvement at week 2, EZ75 at week 16, IGA response at week 16. Again, because the pivotal studies in Dupy went out to 16 weeks. They went out to 16 weeks with this JADE Compare. So this is looking at the results at week 12. We have EZ75 on the left, IGA clear, almost clear on the right. We see 2/3 of the Cibinco 200 patients achieving EZ75 at week 12. 58% of the Cibinco 100 patients are achieving that. You can see a little bit more of a placebo response in this study, JADE Compare. And again, I'll remind you, patients were allowed to use topical corticosteroids. And so I think that helps explain that. We also see the EZ75 at week 16 endpoint listed here just below the blue box. So we see Cibinco 100, 58% of patients, Cibinco 200, 70% of patients. On the right, we have IGA clear, almost clear. And we see over 12 weeks, 47% of the patients on 200 milligrams daily are achieving that. 36% on 100 milligrams daily are achieving that. And we also see the endpoints spacing out to week 16 as well. So patients, when you're talking to them about a medicine, they want to know, does it work? And how fast does it work? And I think this data very clearly shows that this medicine is highly effective at achieving EZ75 and IGA clear, almost clear. And it does so very quickly, which is a big plus for our patients. This is looking at EZ90 from JADE Compare. So we see 46% of the Cibinco 200 patients are achieving that, 37% of the Cibinco 100 patients are achieving that, and that's very impressive. And again, we see a clear separation in EZ90 by week 2. 2 weeks on an oral medication, and already we're seeing 10% of patients achieving EZ90 in only a fortnight. You guys, these people are on medicine on Cibinco for only a fortnight, to quote the wonderful Taylor Swift, and already 10% are achieving EZ90, which is pretty fabulous. Okay. Now let's get to some pictures. We all like pictures. We're in derm. Pictures are our jam. So this is looking at pictures of a 21-year-old male who was randomized to receive Cibinco 200 milligrams and topical corticosteroids in the JADE Compare study. This is him at baseline, IGA 4, meaning severe. Week 2, already significant improvement that's highly visible when you look at these pictures. And then week 12, IGA clear. He went from severe to clear, with improvement that's really highly notable as early as week 2, which is great. So glad to see some pictures in here. That always makes the presentation more fun. This is looking at itch reduction at week 2 in JADE Compare. So this is percentage of patients achieving itch improvement greater than or equal to 4 points at week 2. We have 14% of those patients achieving that mile marker, and 30% of the patients in the 200 milligram group are achieving that. And again, just after 2 weeks, only a fortnight, which is pretty great. Okay, now let's talk a little bit about JADE Extend. So JADE Extend was a study where patients from the preceding studies were allowed to roll into JADE Extend, an extension study primarily looking at safety, but also looking at efficacy over time. Patients who were in JADE Compare in the dupilumab arm as an active control were specifically looked at. So these patients received Dupy for the first 16 weeks. Then they had a 4-week washout, And then they were allowed to enter the JADE Extend study, and they were randomized to receive either 100 milligrams of Sabinco or 200 milligrams of Sabinco. We can look at this patient population and look specifically at the patients who would be classified as dupilumab non-responders. And we see their stats down here. So the number of patients who were on Dupi who didn't achieve EASI-75, 51 patients. The number who didn't achieve EASI-90, 105. The number of patients who didn't achieve IGA clear, almost clear, 107. Okay. What happened to these patients as they roll into the Sabinco long-term extension study? How do they do? These patients who were non-responders to Dupi, how do they do? This is very real life, because a lot of our patients with bad atopic dermatitis have been on Dupi. We've had Dupi for 7 years. So a lot of our patients with bad AD have been on that medication. How do the non-responders do if you switch them to Sabinco? Very practical situation. Well, let's see. So here we're looking at patients, the percentage of patients who didn't achieve IGA clear or almost clear on Dupi, but did achieve IGA clear or almost clear on Sabinco at week 12. So 35% of the patients receiving 100 milligrams a day did that. 47% on 200 milligrams a day were able to achieve IGA clear or almost clear after not doing so with Dupi. Let's look at EASI-75. 68% of the 100 milligram dose patients and 80% of the 200 milligram dose patients were able to achieve EASI-75 on Sabinco after not achieving that on Dupi. And then lastly, EASI-90. 40% of the 100 milligram dose patients and 60% of the 200 milligram dose patients were able to achieve EASI-90 after not doing so on Dupi. Again, a reminder of the recommended dose. You start with 100 milligrams a day, and you can proceed up to 200 milligrams a day if an inadequate response is seen. Just a summary there to call that out and remind you guys. Okay, we've covered efficacy. Now let's talk safety. Very important, especially when it comes to these JAK inhibitors. Here we have our box warning right here, front and center. And whenever I see the box warning, I can't help but hear Taylor Swift in my ear saying, "It's me. Hi, I'm the problem, it's me." Because these JAK inhibitors are so effective and fulfill a niche and a need in dermatology that has not been met before, that they would be flying off the shelves like Ozempic if it weren't for this box warning. It makes everybody take pause, and it's appropriate to keep safety way up here. Safety is number one. It's so important. But this box warning really makes everybody kind of take a pause with these medicines. We're going to talk about it in detail, and we're going to, I think at the end, I think you're going to feel much more confident about having this discussion with your patients and their families. And so like a bridge over troubled water, I will ease your mind, you guys. And we're going to talk about all this. The contents of the box warning: infections, mortality, malignancies, MACE, thrombosis. The reason for the warning, it comes from the Xeljanz oral surveillance study, where they looked at patients with rheumatoid arthritis who were all older than 50 years old, who all had at least one cardiovascular risk factor, who were all also on methotrexate, and 57% of them were on prednisone. And because of some safety concerns noted in that trial, all the JAK inhibitors got the warning. I think everybody in the audience is probably aware of this. Let's see how Sabinco stacked up when it came to these particular AEs of special interest. So we have a well-studied safety profile in about 3,800 patients, representing more than 5,000 patient years of exposure to look at and dive into. So let's look at serious infections. The numbers in parentheses are the numbers, the incident rates per 100 patient years. And it helps put things in context when you lose the placebo group in studies. So it helps put things in context. So we saw a few serious infections, 2.2, 2.7. The big call out here is zoster. The zoster is real. This is very real. JAK inhibitors, likely by interferon gamma, do increase the risk for zoster. And that risk is dose dependent. You can see that here in the incident rates per 100 patient years in 100 milligrams versus 200 milligrams. Next, you see malignancy, non-melanoma skin cancer, MACE, PE, DVT, and you see the numbers per 100 patient years. and they seem relatively low. And you're like, okay, how do I conceptualize that? How do I talk about that with patients? What do I make of this? And I think you're going to have a lot more information to help you make something of it. We have different sorts of trials and studies in the world of medicine, and they each have their pros and their cons, their strengths and their weaknesses. We have randomized clinical trials, which is like what has taken place with Sabinco with the JADE clinical trial program. And then we have real world observational studies that do provide good information, but it's tempting to make absolute direct comparisons, but you wouldn't want to because these are different. They're different modalities, different ways of doing it. They each have their own strengths and weaknesses. The way I think about this is I think about, you know, the Bachelor is great and Bachelor in Paradise is great, but you wouldn't want to compare them. No, they stand beautifully on their own. You gain a lot from each one, and you wouldn't want to compare them head to head necessarily. You want to take little bits of information from each and tuck that away. Okay, so that prefaces this next slide, because what we have here is we have a few AEs of special interest, MACE, VTE, and malignancy, from the Sabinco clinical trials in Sabinco 100 and Sabinco 200. And we have in parentheses the incident rates per 100, or I'm sorry, not in parentheses, the non-parentheses number is incidence rates per 100 patient years. Okay, so that comes from the trials. Down below, we have data from a retrospective study of a demographically matched cohort of patients with atopic dermatitis from the Kaiser cohort, taking information from 2007 to 2018. And we see here the incidence rates per 100 patient years of MACE, VTE, and malignancy in the Kaiser cohort. I'll just let you guys sit with those numbers. Again, these are different types of studies, so you wouldn't necessarily want to do a head-to-head comparison between the Bachelor and Bachelor in Paradise, but they are both important, and we get good information from both that we can learn from and grow and understand. Okay, good. Hopefully you guys had some good time with that. Now, some other adverse reactions that occurred in greater than 1% of patients taking Sabinco, and more in the Sabinco group than in the placebo group. So that's how this list was generated. And we see common stuff from studies like nasopharyngitis and things. I want to focus on a couple things that call out to me. So first, we see a little bit of tummy upset issues, nausea, abdominal pain, vomiting, so a little bit of tummy issues. This was most common at the beginning of treatment, and it tended to get better, and taking it with food tended to help. So a little tidbit there. Headache does appear to be a little bit of a risk of headache. It does appear to be real. It does appear to be dose dependent. Headaches tended to resolve very quickly too, within a few days. Herpes simplex, this is real. JAK inhibitors increase the risk for cold sore virus and shingles. This is a real thing. And so we see that popping up here, and it appears to be a bit dose dependent as well. Acne, that's worth a call out. What we call JACNE, right? We did see a bit of JACNE in the studies. We're dermatologists. We can handle a little bit of acne, but we did see that here in the study a little bit. And then down to the bottom of the right row, herpes zoster, again, worth a call out. The shingles increased risk is a real thing. And then thrombocytopenia, we saw a few patients in the 200 milligram Sabinco group that developed thrombocytopenia in the first 3 months. It self-corrected, but that is the reason why you are to avoid antiplatelet therapies with the exception of baby aspirin during the first 3 months of Sabinco treatment. Okay. Those are the highlights that I see here. Discontinuation rates were in general low and were higher in the placebo group than in the Sabinco groups. And that's really telling. If patients are happy with the medicine, they're finding improvement from a medicine, they're tolerating the medicine, they're more likely to stay in a study. And if you see a higher rate in placebo, that makes sense, right? Because their atopic dermatitis is likely uncontrolled. In fact, we see here the most frequent AE leading to discontinuation was atopic dermatitis, occurring more frequently in the placebo treatment group than in the Sabinco treatment group. Other reasons for discontinuing were in the Sabinco group were nausea and headache. Okay, perfect. Okay, so we've covered that well. Now, let's talk practical stuff. starting your patients on Cibinqo. And this was actually one of the things that I probably struggled with the most when the JAK inhibitors started coming out. How do I thoroughly and efficiently discuss the efficacy and safety of this class of medicines in a busy clinic without getting too bogged down, without running behind, and without potentially giving patients too much information that might overly scare them? And so I, through a lot of practice and a lot of rough drafts, eventually came up with a spiel that I find helpful in clinic. And the first thing I start by doing is I ask patients about their past medical history. I ask patients if they were ever a smoker. I ask patients if they've ever had a blood clot. I ask patients if they're thinking about getting pregnant, the female patients. I ask them if they're thinking about getting pregnant. I ask people, I get a good sense for their overall past medical history and any comorbidities they might be dealing with. I also ask them about any medications that they're currently on. And I make sure that I do an interaction check on my Hippocrates app if they're on other medications to make sure that everything is cool. If I have gone through all those motions and I think an oral JAK inhibitor would be a benefit to them, then I say to them, okay, now there's this medicine, this class of medicines called oral JAK inhibitors. Cibinqo is one of them. And this class of medicines offers an ability to rapidly improve atopic dermatitis, especially with regards to itch. These medicines work super fast. They have a little bit more safety baggage to them that I can sum up in 3 things. Number 1, we do have to do labs with these medicines. I personally, there's no hard and fast schedule of laboratory monitoring. Everybody's doing a variation of relatively similar routines. I'll share with you what I do. So at baseline, I do CBC with DIF, CMP, lipid panel, quantiferon gold, Hep B, Hep C. Then I recheck CBC, CMP, and lipids after 1 month, then 3 months later, then 6 months later, then every 6 to 12 months after that. I will possibly recheck quantiferon, Hep B, Hep C annually, depending on the patient and the clinical context. So that's how I do labs. So that's safety thing 1. Safety thing 2, these medicines do increase the risk for the cold sore virus and shingles. Do you have a history of cold sores? Do you want to get vaccinated for the shingles? Most importantly, it's important that patients know there is a slight increased risk of developing these things, and these things are treatable. I can prescribe medicine to help them with them. So if they start getting cold sores, if they notice a one-sided, painful, blistery rash, please call me. I can start you on medicine that can help calm that down very quickly. And number 3, there is a boxed warning on this class of medicines called JAK inhibitors. I tell them where the box warning came from. I tell them a little bit about the Xeljanz oral surveillance study. And I say the FDA thought it prudent to put this warning on all JAK inhibitors, including Cibinqo. I've reviewed your past medical history. I've reviewed your medication list. And I think that the benefits of this medication far outweigh any risks that would apply to you. And so that is my spiel. And I can get through it pretty quickly, thorough yet efficient in the office, so it doesn't bog me down. But I've also put all the pertinent information out there. I've gathered a good medical history. I've gathered a good medication list. I know what we're dealing with there. So Cibinqo, as we know, you start with 100 milligrams a day, and then you can go up to 200 milligrams a day if inadequate response is seen. It can be used with or without topical steroids. It should be taken around the same time of day. It can be taken with or without food. I tend to recommend my patients take it with food just to minimize the risk for tummy upset. You should swallow them whole. They shouldn't be crushed, split, or chewed. And then there is a lower dose available for special patient populations and patients with certain drug interactions. The 50 milligram dose exists, it's out there for those special patient populations. And so that's important to know about. This is a little bit of a busy slide that basically goes over what I talked about in terms of talking to your patients about their past medical history and doing appropriate labs. This is basically a little bit more of an elaborate view of all of that. Things that are important specifically to know when you're considering a JAK inhibitor. from a past medical history perspective. Number one, smokers. A patient who's a smoker is probably a no for me for an oral JAK inhibitor. Patients who've had a history of blood clot, DVT, PE, those patients are probably a no for me for an oral JAK inhibitor. Number three, pregnancy. If they're anticipating a pregnancy or they are pregnant, that's a no for me. And then history of malignancy, a little bit depends. What was it? How long ago? How far out of treatment are they? Maybe I have a conversation with their oncologist to talk about, pros and cons and all of that kind of stuff. So those are the big important things. One thing that's worth mentioning on this slide, you'll see down here at the very bottom of the box, advise patients of reproductive potential that Sabinco may impair fertility. What? This has raised red flags. If people read the package insert, they will read this. And so I address it right there in the exam room as we're talking about Sabinco. The reason this is in there is because of a study done on rats, where they gave the rats big doses of Sabinco, and they found that it impaired the rats' fertility. Once the rat patients were off Sabinco for a month, their fertility returned to normal, so they were able to have the little rat family that they always dreamed of. And so that's why this warning is in here. It is because of the rat study. But I think it's important to tell patients about it so they don't read about it later and then get overly concerned. Okay. So we did all that. Now, let's tackle just a little bit of a summary of important safety information. We've done all the hard work, you guys. We're in the home stretch. This is summary time. So laboratory abnormalities have been observed with oral JAKs. We need to check blood work when it comes to these medications. Most importantly, CBC, CMP, lipid panel at baseline, after 1 month, 3 months after that, 6 months after that, and every 6 to 12 months. That's how I do it, with a baseline screening of quantiferon gold, Hep B, Hep C. Immunizations. Encourage patients to catch up on any immunizations before starting the medicine. Do they want to get vaccinated for the shingles? Well, go ahead and do that before we get started, that sort of thing. And avoid live vaccines. The two most common live vaccines are MMR and chickenpox, and they're typically given between the ages of 1 and 2, and again between the ages of 4 and 5. So it would be unlikely for you to encounter that in an adult patient population, but you never know. Years ago, there was a big measles outbreak, and I had my antibodies checked, and turns out I was not immune to the measles, so I had to get an MMR. So occasionally an adult will need a vaccination like that. Check baseline labs. Identify any renal impairment or hepatic impairment at baseline. That's important. Adverse reactions. We see this long list of things that were reported in the study, things that occurred greater than 1% of the time in the Sabinco group and more in the Sabinco group than in the placebo group. That's how that list was generated. I think we covered the hot points there. And then drug interactions. Get your Epocrates app out. Type in those medicines. I can't remember which drugs are metabolized by CP, blah, blah, blah. I can't remember that. So I go ahead and get my Epocrates app out, type in the names, see what pops up. Use in pregnancy seems like not a great idea. And so anticipating pregnancy is a no for me when considering an oral JAK. And there is a pregnancy registry that's keeping track of any patients who have gotten pregnant on the medication. And then lactation, probably a no as well at this point in time. Perfect. And then now we're at the end. We made it, you guys. We are at the thank you slide. Thank you so much for tuning in. Thank you so much for listening. I hope you got something from it. I hope you learned a lot about Sabinco, about The Bachelor, about Taylor Swift, and happy to answer any questions you might have.
So remember, if you'd like to submit a question, submit it in the question chat pane on the right-hand side of your screen. And if you think of any questions after the webinar, you can always send it to info@idefeducationalseries.com. Again, we would like to thank our supporter, Pfizer, for making this educational event possible. And please join us next Tuesday when we are going to be talking about oral treatment for severe alopecia areata with Dr. Jennifer Song.
All right, so we got 2 questions then for you, Dr. Swanson. That was incredible presentation, and I love your jokes. We know you didn't make the presentation because there's no pictures of your dogs.
Right, exactly. Yeah, I know. It's too bad too because they're really cute.
Yeah. Well,
Yeah.
you did a really great, I would say you did a really great job. It was great to get in your head. I was actually taking a lot of notes for hearing you talk about it. So I really love the way that you think about it, Lisa.
Hey, Sean Quadra,
Um,
that's powerful. Thank you.
absolutely. So then we have a first question for you that came in, like, how do you decide when it's time to
Hmm.
start a patient on a JAK inhibitor? What are the thoughts that go through? What are the therapies you may try at first? What's going through Dr. Swanson's head?
Yes, yes, a lot of things, a lot of things. But I think one of the easiest contexts where I think about a JAK inhibitor is in a patient who has had a suboptimal response to Dupixent. We've had Dupixent for 7 years. Most patients with bad AD have been on it at some point in time. So a patient who has had a suboptimal response to Dupixent, I would definitely present an oral JAK inhibitor as an option for them. I think about their comorbidities. Do they also happen to have something like alopecia areata, something like vitiligo, that is a condition that could possibly benefit from JAK inhibition? And then we could, treat two things at once. We're not supposed to use the expression kill two birds with one stone anymore. It's feed two birds with one scone now. That's what we're saying now. And so asking about that, certainly their past medical history, their general health, that's going to factor into my brain thinking about, is this patient right for a JAK inhibitor? Different patterns of atopic dermatitis, particularly those patients that tend to have the bad kind of eczema psoriasis overlap on their hands and feet. I have found oral JAK inhibitors to be really powerfully effective for those patients. So that's kind of it in a nutshell, the patients that I consider. And really, anybody who feels miserable with their atopic dermatitis, anybody whose itch is out of control, anybody who's 12 years old and dealing with bad, at least 12 years old and dealing with bad atopic dermatitis, I think it's worth discussing. I also find in my clinic that I want to mention these treatments that are available to them, because I don't want them going home and then seeing a commercial for one of these medications and wondering, why didn't Dr. Swanson tell me about that? Why wasn't she mentioning that and letting me think about that? So I will frequently bring it up as long as they're a patient 12 and up with moderate to severe AD. And sometimes it just plants a seed that will maybe fester over time, and their interest in the medication class will grow over time, and then we'll start it.
Awesome. That's great.
Yeah.
Okay, so another question. You already alluded to this. We were in Dr. Swanson's head when
Yeah.
you were talking about how you go about thinking about starting a JAK inhibitors. Can you expand a little bit more? Because we got a lot of input in the audience. This is what people want to know. Like more about, expand upon it a little bit more about the script and how you say it and how you talk to people and how you bring it up and how it kind of occurs and how you do that within a quick clinic visit. I was amazed by you when you were listing all those things, and I was thinking 15 minutes, 10 minutes dermatology visits, and I was thinking, can we run through that again? Like, how do you talk to your patients
Definitely.
about getting started on the JAK? Like, I think that's very high value. People in the audience want to know that.
Yes, oh, definitely, definitely. So say I'm seeing a patient 12 and up, moderate to severe AD. I'm going to take my Dr. Swanson's favorite things list, which has a list of sensitive skincare products that I think they should be using, and I'm going to point that out to them. And then I'm going to flip it over, and I'm going to write down the different options for them. Topical corticosteroids of varying potencies, TCIs, Opzelura, since they're 12 and up, Opzelura. And then I'm going to draw a line, and then I'm going to write Dupixent, and I'm going to write JAK inhibitors, either Cibinco or Rinvoq, which is our other oral JAK inhibitors, and I'm going to quickly go through each one. And then I'm going to get down to the oral JAK inhibitor headline, and I say, okay, now we have this class of medicines called JAK inhibitors. They work super fast. Speed is their thing. They're like the Ricky Bobby of medicines. They work very fast, right? Super fast. And that's wonderful. And it's
If you're
really
not first, you're last. Sorry, I had to. I had to interrupt you. Go ahead.
And so they work, they're very powerful, they're very effective, and they work very quickly, and they'll make your itch better. Their itch data is impressive. They have a little bit more safety baggage to them, which I can sum up in 3 points. Number one, we do have to do blood work with this medicine. Number 2, there is an increased risk of cold sore virus and shingles. Do you have a history of cold sores? Do you want to get vaccinated for the shingles? If you're age 19 and up, you can get vaccinated for the shingles. Number 3, there is a boxed warning on all the JAK inhibitors, every member of the JAK inhibitor class, regarding some safety concerns that stem from a study on a medicine called Xeljanz in patients with rheumatoid arthritis. And because of the safety concerns that stem from that study, the FDA thought it prudent to put this safety warning on all JAK inhibitors. I've reviewed your past medical history. I've reviewed your medication list. And I think the benefits of this medicine far outweigh any risks to you in your clinical situation.
Ooh, man, that's good. You got away to you. I must say, I love the way you put that. I was actually typing some notes and taking some notes too, because I thought that was so helpful. Well,
I was so good. Okay.
yeah, thank you again. You know, Lisa Swatson, you're one of a kind. That was phenomenal.
Thanks, guys. Thanks, Roxanne, too. Thanks for having me.
Absolutely. Well, thank you, Dr. Quattro, for moderating this meeting, and Dr. Swanson for a very interesting and very thorough presentation. We love the tips. And thank you all for joining us this evening. Good night, everybody.